I will read the right bottom first, the sentence after figure 37.16. A curved clamp is then passed retrogradely through the pulmonary valve as a guide to locate the incision on the anterior aspect of the right ventricle outflow tract, 3 or 4 mm below the lowest point of leaflet attachment. Figure 37.17. Now we are going to that point, to that figure. This is in the left, the incision in the right ventricle outflow tract below the pulmonary valve, about 3 or 4 millimeters. The incision is carried out medially, taking the full thickness of the anterior wall of the right ventricle. One should try to avoid the conus branch of the right coronary artery as the incision is carried toward the aorta. Posteriorly and to the left lie the left main coronary artery, the left anterior descending coronary artery, and the first septal branch, which are all at risk during this dissection. Now we will see this branch, the right coronary artery in the left, figure 37.17, and left coronary artery from the back of the pulmonary artery goes the first branch, and left anterior descending artery. The septal branch is avoided by making an oblique incision deeper on the endocardial than the epicardial site. The endocardial incision is first made with fine scissors from within the right ventricle outflow tract. The inoculation of the pulmonary valve is completed with scissors angled to leave the epicardium intact. Figure 37.18. Now we will see that pulmonary homograft has been cut. Any bleeding points in this dissection vote area shown up at the time of cardioplegia delivery into the left coronary artery should be diathermized or carefully oversewn with fine pro-length sutures. The aortic valve is excised and the pulmonary autograft root is inserted into the subannular aortic position using the technique described for the insertion of an aortic root homograph. The autograft is trimmed of all excessive muscle up to within 2 mm of the cusp insertion, and any loose tissue is removed from the pulmonary arterial wall. Now we see how pulmonary homograph will sew into the aortic root. The proximal suture line can be constructed in a variety of ways, including continuous sutures, single intraepithelial sutures, or matrix suture with or without reinforcement. We prefer the use of intraepithelial 4-0 Ticron sutures reinforced with a strip of autologous pericardium for the proximal suture line of the autograft into the left ventricular outflow tract. The suture line is subannular. So that the autograft root is well supported by the fibromuscular lot. The orientation of the autograft follows the slight curve, and the left and right coronary arteries face a sinus. The coronary arteries are implanted into the autograft, avoiding rotation, tension, and kinking. Now we are going to figure 37.20 and 21. Here is in the left 20. Here is the suturing of the pulmonary autograft to the aortic annulus, and here is the 21 in the left down, and we see that how right and left coronary cusp are reimplanting to the homograft. The right ventricle outflow tract is reconstructed with a pulmonary or an aortic homograph of appropriate size. The distal suture is carried out first, placing the sinuses of the homograph into the appropriate positions, 2 sinuses facing the aorta. Figure is 37.22. Here is the distal ascending aorta. The distal aortic suture line is completed without tension. The authors would also reduce the dimension of the dilated distal ascending aorta if present to protect the newly created synotubular junctions. This can be easily achieved by either triangular anterior aortic valve resection or the placement of several plicating horizontal prolonged sutures. The proximal remote homograph suture line is carried out before the aorta is unclamped. Hemostasis and avoidance of damaging the left coronary artery system are particularly crucial during this anastomosis, which has to be performed on a relaxed heart and in a bloodless field. Anteriorly, the suture line takes the full thickness of the right ventricular outflow tract. The completed operation is shown in figure 37.24. In the figure 37.23, we see how the pulmonary autograph is hewn and how left coronary artery should be protected. Now we are going to the figure 37.24. This is the complete version of the operation. The pulmonary autograph in the aortic position and the homograph in the pulmonary position. Relief of subvalvular aortic stenosis, resection of subaortic shelf. This operation is performed on hyperthermic cardiopulmonary bypass with B-caval cannulation or a single atrial cannula for the venous return. The cold blood cardioplegic solution is infused into the aortic root if the aortic valve is competent, or directly into the coronary arteries if there is more than mild aortic valve regurgitation. An oblique aortotomy incision extending into the non-coronary sinus is performed. The aortic valve is inspected. The right coronary cusp is retracted anteriorly, exposing the subvalvular obstruction. A modified nasal speculum is sometimes useful to retract the aortic cusps and expose the subvalvular area in small children. The fibrous shelf is grasped with forceps, and the vertical incision is made into the shelf to the left of the right coronary cusp. A combination of sharp and blunt dissection is used to enucleate the circumferential shelf of the ventricular septum and the anterior leaflet of the mitral valve. The figure is 37.25. You see it in the right top. The aortic valve cusps are retracted and the subvalvular obstruction has seen and is trimmed with circular line. McKay and Ross described the technique of blunt dissection using a Watson chain dissector to peel off the fibrous tissue from the subaortic area. Limiting the dissection to the fibrous tissue in the area of the membranous septum is particularly important to avoid the conduction system. When the fibrous shelf is attached to the undersurface of one or more of the aortic cusps, it is carefully shaved away from the cusp tissue with a knife. Any fibrous tethering of the left and right fibrous trigones in the subaortic region, including the anteromitral leaflet, should be carefully released to widen the left ventricular outflow tract. Once the fibrous component of the obstruction has been enucleated, we routinely perform septal myectomy because the ventricular septum is nearly always significantly hypertrophied. The technique is similar to that utilized for diffuse fibromuscular stenosis or obstructive hypertrophic cardiomyopathy. The figure is 37.26. The stitch has done in the ventricular septum, then it has cut in a square version. Also, the resection may be less extensive. In a narrow aortic root, myectomy is sometimes not feasible. Myotomy